All right, to get us started. So when we talk about epilepsy treatments, can it differ as the child grows? For example, phenytonin was effective when he used it in his first month of birth. However, at approximately 13 months, was loaded via IV for uncontrolled seizures, and it didn't work at all. So that's probably you, Heather.
Yeah, so the short answer is yes. Epilepsy treatment can change over time and your response to medications can change over time, and that can go both ways. With phenytoin in particular, one tricky thing, if we're talking about the gain of function spectrum, is that we often need very high levels where you're teetering between what can be tolerated and what's going to cause toxicity. So it's a very challenging medication to manage in these patients because it can be very helpful, but you need much higher levels than we do in some other epilepsies. And so you give a little bit more and they are suddenly vomiting and really sleepy. You give a little bit less and they can go into severe seizures. So that's very tricky. But yes, epilepsy is not, you find your combination and that works forever. It's going to be likely a moving target over time and an ongoing conversation.
Okay, a couple autonomic questions here. Can an SCN2A patient have both autonomic insufficiency and PSH intermittently?
Absolutely, without question. When I see situations like that, that's when I go and look at medication lists and see if there are interactions that may be occurring that may be causing somebody to experience both. Many of the medications that all three of us use to treat things like epilepsy, movement disorders, have autonomic nervous system side effects. So sometimes we end up having a presentation of PSH, but when another medication peaks, we get some autonomic insufficiency symptoms because that medication has some autonomic side effects to it.
Okay. How do SCN2A mutations correlate with dysautonomia? So more loss of function and gain of function variants associated with different types that you've seen in clinic?
So I will honestly say both in gain of function and loss of function patients, I have seen autonomic dysfunction, and I have not yet been able to make any correlation between gain or loss in terms of PSH versus autonomic insufficiency to this point in time.
Okay. Dr. Kaufman, do you do telehealth visits?
So the rules under which I practice at Mayo are similar to my colleagues. First visit has to be in person. Then subsequent visits can be telemedicine just because of licensing and state medical licensing issues.
Okay. That's the same for for you all as well.
For us, we have to see people at least once a year in person. We can do telemedicine in between.
Okay. How does puberty affect autonomic dysfunction? Can it affect autonomic?
Yes, it can, and it can be wreak quite the havoc, just like it can with epilepsy control. Yeah. Anything that stresses the physiology, right? The function of the human being is going to affect the things that the three of us and all the rest of your medical team try to keep under control, whether it's your movement disorders, your sleep disruption, your autonomic dysfunction. Anything that stresses the way the body works is going to make all of the problems that we treat worse. It's like at times it feels like whack-a-mole, right? And that's what we're here for.
A couple of these are very, very similar, so I'm going to kind of try to put them in together. Are there common anti-seizure medications that you know that interact poorly or cause autonomic side effects?
So that's way too hard to generalize because you have to think about the chemistry of each agent and how that medication interacts with other medications. So what people like us do, managing complex care patients, managing complex epilepsy patients, we open up whatever pharmacology book our hospital subscribes to, put all the medications in, run it through an interaction calculator, and look for problems.
Very common that I see sometimes like to use benzodiazepines as part of epilepsy management, or movement disorder team uses for dystonia, spasticity. So you're on Klonopin and clobazam and lots of different things. So when you already have low blood pressure or forget to breathe sometimes, and then we slap more benzodiazepines, we can worsen that problem. So not directly cause issues, but worsen the underlying issue.
For some of the anti-seizure medications, we're checking EKGs for specific heart rate problems, not necessarily broad autonomic dysfunction, but specific heart indication.
If meds don't help PSH, is there a surgical option treatment like deep brain stimulation or something like that? Would that help with autonomic issues?
Not of which I am aware. There's never been any study. Part of the reason is trying to do what we as neurologists do, which is localize where the dysfunction is in the brain, has been remarkably challenging in PSH, regardless of whether it's genetically induced or brain injury induced. The best thought currently is it's a problem with the hypothalamus. However, the hypothalamus has multiple different nuclei, so different groups of nerve cells that have different functions. So no one's been able to say, here's the spot that you could put a DBS electrode in and treat the autonomic dysfunction.
Probably for Dr. Stenari, what recommendations would you give to a family who does not have a complex care team at their local hospital?
Yeah, that was kind of what I was alluding in the end. So not everybody lives next to Harvard or a big medical center. So coming into conferences like this, listening lectures, asking questions, meeting other families. I think big thing nowadays is family support groups. So find your team, listen to what other parents and other families have found to be useful and beneficial. I learn from my parents all the time. I might have one child with particular mutation and disorder, but when families ask from their parental support groups, you know what, this is kind of what's helpful, bring it to your provider. That also is a collaborative team work and team effort. So using like a broader spectrum of reaching out is very helpful.
And Keith, I heard you say yesterday, you were talking a little bit about the concept of like a quarterback. Do you want to like having a quarterback for your team?
Yeah. So, complex, one of the concepts, places that I've practiced in the past have had what are called complex care pediatricians. And these are typically hospital-based pediatricians that specialize in the care of medically complex children. When you're out in the community, if you're not in a major medical center, one of the things that I've had a number of families do, because for the last 10 years I was in Kansas City, which gets very rural very quickly outside of the metro area, and now I'm in Minnesota when it's very rural outside of the three major cities. And what you do is you interview pediatricians or family practitioners and say, what experience do you have managing medically complex children? And there are primary care physicians out in communities, even rural communities, who have a decent amount of expertise in doing this. And it's really just like you would for any other position, interview people. Makes sense.
Final one, I'm not sure if any of you all will be able to answer this. It may be more of a basic scientist question, but are there animal models of SCN2A that show dysautonomia or autonomic symptoms?
I don't have a clue. I left my basic science career long ago.
There are animal models. I don't remember them talking about very specific autonomic features that have been identified. Many of them are in the room.
I don't know, Sean may be able to answer that. I don't know where he's at. Is Sean in here? No, he's not, of course. Okay, I think that is it. That's all the questions we have. So again, let's give a round of applause for our presenters today.